Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
So today is our Best of ESMO 2025 episode. Got a few abstracts we're going to talk about that are essentially all in the melanoma section. Okay, but before we do that, so you've now been on holiday for a couple of weeks post-ESMO. So do you have a favorite childhood holiday memory?
Oh, we didn't used to go on holiday much when I was a kid.
Really?
Not too much.
That should make a few times very memorable then.
Yeah, definitely not before I was 9 or 10. No, not really. We always used to, when we did start going on holiday, I think we'd only really go on holiday once a year, and it would usually be to the same place, I guess. So, I mean, I don't know, this is boring, isn't it? I can't, nothing's standing out. You should have pre-warned.
Where's the same place? Where's the same place you used to go?
Oh, we used to go skiing in Austria a little bit.
That's not boring at all. Oh my God. So sorry that was so plebeian for you.
We used to go on this bus as well, right? Literally the bus would drive all the way from London to Austria. Yeah, exactly. And we had to get from Cornwall to London to get on the bus. So it wasn't a minor thing to do. And then we always used to go on summer holidays to Mallorca as well, which was nice. I don't want to belittle it.
Yeah, those are good holidays. When did you learn to ski?
I think about 9 or 10. Bit of a long story, but my dad's cousin was a ski instructor, British. And then in this place called Ipswich, which is in Suffolk. So then they had this dry ski slope. I don't even know if these things exist anymore, to be quite honest, but it was this made out of toothbrushes, almost upside down toothbrushes. So my brother and I learned to ski for a week. I guess we were 9 or 10 at this dry ski slope before we actually, which is a good thing, because then when we went skiing, we could, obviously you're fearless at that age, aren't you? So, yeah, cool. But I never got any good.
That's a nice story.
Okay, with the upside down toothbrushes.
No, I don't know if you've ever thought about it, but at some point somebody's going to ask your kids as grown men, hey, what's your favorite holiday that you've gone on with mom and dad?
I'll probably give the same answer. It was all boring. Right. Okay. Best of ESMO. Right. So what order are we going to do this in?
Okay. Well, neither of us have our email open because it slows down the recording bandwidth. So let me look on my phone.
I think Neoadjuvant, no? Wasn't that number one?
Yeah. Yeah. Okay, go. Neoadjuvant.
Oh, okay. 3 presentations. I can just about remember that much. S1801, Nadina, both updates basically. And then the final one was basically people who didn't get a good response, I think it's 1 dose, wasn't it, of neoadjuvant Nevo, then getting randomized, I think it was randomized to Ipi-Nevo in that situation, or you could carry on with Nevo with loads of correlative work there as well. From your face, it looks like I went wrong somewhere there, but I think that was roughly the idea of it. No,
I think it's right. I think it's right. Maybe I'll just give the update on S1801. We did 3-year.
Can I ask why you didn't present S1801, Dr. Patel?
You're part of the ESMO elite. You know the reason for this kind of stuff.
I didn't know there was an ESMO elite. Come on, stop being modest.
He says with a laugh. Because you can't have 2 proffered oral presentations at ESMO. And so I had another one and they wouldn't let me do 2.
In the presidential symposium. For which congratulations.
Thank you for saying all of that. Very kind of you. And for the record, I wore the same dress that I wore 3 years ago for the presidential. 3 years ago for the
Yeah.
presentation.
So that's a big achievement. Come on, you know,
Yeah.
two. Yeah, I know it is two pretty much completely separate things. Academic study, industry study. It's great. It's fantastic. Anyway, I've said that.
Well, okay. Let me just stop being immodest about it and just say it was a shock the first time around. Obviously, S1801 felt like it was a nice study for us, but we didn't quite grasp the scope of it. I think once it got presented, once Lex Egremont, sort of says we're no longer practicing the same way Monday morning based on this presentation, I think we clearly started to feel the impact of it. And then this small study that we'll talk about a little bit later here that made presidential also very shocking. But, I now understand the motivation for putting something like that on a big stage and giving it the light. And then just to say, because obviously you and I've talked about this now for a long time. In theory, we've talked about it for years, but about this most recent one for at least a few weeks. And um, it's nice to have a friend like you who's really like happy for somebody like me when this happens. Because
You got lots of friends who are happy. Uh,
yes, I did. I guess I didn't mean it like that. I meant to say it's nice to. It's just nice to have a champion for this. Like it feels like you're genuinely happy and not just making gags on a podcast.
I wouldn't
So
want you to think that I'm not going to make gags, but
I know they're coming. Anyway, thanks for all your support. Okay, so I moved the thing away. Okay, so S1801, and thanks to Vern Sondak, who did a great job presenting.
yeah, I agree with that, by the way. Really, really great job.
He really, we kind of stuck this on him with very little warning, just maybe a couple weeks' notice. We crafted the slides, but he was very involved in how he kind of wanted the slides to flow and look. And he did a really lovely job. So we presented all randomized patients here, not just the sort of quote unquote eligible. So for kind of astute listeners, the NEJM paper and the original presentation from years ago had about 100 and maybe 30 some patients randomized in each arm. And now it's about 150, almost even 170 patients per arm. And that's because eligibility required RECIST measurable lymph nodes that you and I both know is short axis 1.5 centimeters. And here we said, okay, let's just take everybody. As long as they had a lymph node, as long as it was in the spirit of giving neoadjuvant for palpable lymph node disease, let's not obstruct. It's an exploratory analysis at this point at 3 years. We thought it was good to include those. And by the way, that may be the patient you treat in the real world. You may not be so precious as to wait for a lymph node to be 1.5 centimeters. So at 3 years, the signal maintains for both event-free survival and recurrence-free survival. The neoadjuvant adjuvant is better than adjuvant-only pembrolizumab. We did not, de-escalate adjuvant therapy here. We did not do any response-driven personalization. So basically, regardless of your response, you still took adjuvant pembrolizumab. And just to sort of make the point that I typically make is if you've had a complete pathological response, does that tell us anything about micrometastatic disease that might be left behind? Not really. It tells us about a response in macroscopic disease that we went and removed. But does it tell us if we've mopped up all your micrometastatic disease? I'm not certain. For a near pathological complete response, I may be even a little less certain, even particularly based on some of the NADINA data. And then for a non-responder to neoadjuvant immunotherapy is not the same as a progressing patient. A non-responder means in this 6 weeks, 9 weeks of neoadjuvant therapy, you didn't run as fast a race as we wanted. It doesn't mean you're not still conditioning the immune system. So I don't think a non-response to neoadjuvant immunotherapy means you have to throw away the regimen you gave in the neoadjuvant setting. I do concur that there's probably a better regimen then that could get you from conditioning to running the race fast. But I don't think it just means throw the baby out with the bathwater. The regimen didn't do any good. That's not, to me, what that means. I think in a patient who's progressing, on neoadjuvant therapy. So they're progressing in a way that their lymph node is doubling, or they can no longer have the surgery. Yeah. Then I think your regimen is not great and it speaks to the biology of that tumor. But I don't think a pathological non-response or even a partial response of, 50% viable tumor. I just don't think that means that the regimen is garbage. I think it just means that the system hasn't jumped as fast as we want it to. So that's just a soapbox I often get on. We it sounded
That
like
was nice. I enjoyed all those metaphors anyway.
it
There were
sounded
a lot of
like
different. What?
effing get on, but I meant to say often get on. Anyway, we also did a look at overall survival. Still immature. We don't have a lot of deaths on either arm. And so right now, the signal looks like there could be a trend, but it could go either way, frankly. It could be no signal in overall survival. It could be a clear signal in overall survival. We just need more deaths to be logged and registered. So I think longer follow-up for overall survival is the real message. Let's not read too much into that. For stage 4, resectable melanoma, neoadjuvant adjuvant looks incredible. The delta between those two curves looks really large. So if you've got stage 4 resectable, in my mind, the next question is, should you resect and give adjuvant ipi-nivo like Immuned? Or should you leave it in place and give perioperative pembro? And then frankly, even let's argue an Adena regimen, maybe just neoadjuvant and then see what happens. Based on pathological response. So that's my whole take on that. We presented some updated mucosal acral. Let's not make too much about that. The numbers were so small. Every single mucosal patient got randomized to neoadjuvant therapy. We can't say for sure. I still am not certain. I give, in my practice, I don't give a lot of mucosal as adjuvant therapy. I don't have heartburn about giving them neoadjuvant therapy, but then I probably will give them the Nadina regimen. Acrals, I don't know. I mean, our data set is small. It's only about 9 patients, and I don't think it convinces me one way or the other. So I think you're not wrong to give neoadjuvant if you'd like, if you can still resect it, but I don't know if the signal is as strong there. That's the end of S1808. I mean, S1801.
Yeah, I mean, it was great to see that, wasn't it?
Obviously, that's a joke because Sweet Bart, when he made his discussion, had his slide set S1808 all over it. So
I think inevitably people are going to look at the OS though, and actually, I think Mark O'Donoghue, when he did the best of type of slide, and he didn't say it. We need to be careful. I don't want to get into trouble with Megan or anything else, but the p value for OS was 0.06, right? So that's quite striking. Obviously, not statistically significant.
well, technically, and Megan can certainly, we should probably just ring her up and ask her. Should we just do it middle podcast? Just ring up Megan and say, hey, technically a 0.06 is significant per the design. So, per our design of alpha 0.15 and anyway, but yes, if we're purists and we're looking for the 0.05, it's a few events shy of that. The trend looks like it'll favor it, but let's see.
Yeah. Okay, great. I definitely think you should talk about Nadina as well, because
Okay.
well, not that I sort of don't want to, but the obvious question and what people are going to be thinking about, I think, is the comparison, whether we like it or not, between
Well,
S1801 and Xena.
Nadina's only doing 2-year follow-up, of course, but look, also has very striking maintaining of benefit of their neoadjuvant regimen over adjuvant only. Um, First of all, Minky did a wonderful job presenting, as you and I said, and she's really very measured about the way I think she presents the data. So she showed the recurrence-free survival by pathological response, and you can start to see these near pathological complete responses. So 10% or less viable tumor in the specimen. They're starting to pull away from pathological complete responses and they're starting to have some recurrences. Not all of those patients, but some, to the point where they're going to investigate those and look a little closer. Is there a biomarker that might have predicted they wouldn't get a complete response? Is there a biomarker that would have predicted progression or recurrence? And or which portion actually needs adjuvant therapy or something else. So that's number one. The main gist of their study, though, was not longer survival updates. It was this biomarker stuff. So they did some work looking at TMB, interferon gamma, um, and some of this they had done in their Donomy trial, that you might be able to start to personalize neoadjuvant regimens based on um, these signatures. But you're giving a lot of side face to the camera. What's going on over there?
Oh, is that bad? No. I was just looking at the slides actually.
You're looking at your laptop.
Yeah, sorry.
No,
Yeah.
it's just, for the, I mean, you have a good jawline, so I guess
Oh,
you're
that way. despite my
um,
despite my 3 weeks of just eating and drinking and not exercising post ESMO, it's true.
not fair. You're a man. Okay, so do you see anything? Do you see anything on those slides that is worth pointing out?
No, I don't. But it's worth saying again. I think Minky Lucas really did a lovely job, and the pitch was just right as well. And I guess one of the most exciting things is that hopefully before too long we're going to see sort of, let's say, more definitive OS from both studies. That's one thing.
We didn't see any OS from Nadina,
Yeah.
is what you were trying to say, but yeah.
Yeah. And then I think there's still these unresolved questions about major path response that you've alluded to very nicely. And then this whole idea of, whether there's something that you can measure at baseline to pick a regimen, that's great as well. So it's I mean, big picture here, it's all pretty exciting, I would say.
The thing they've been doing so well in the Netherlands, Christian and that group, is they don't just not even necessarily look at baseline. They look at baseline and then after, neoadjuvant. So they do a sample before surgery. And, there's a lot of information to be gleaned there, but it would be very helpful if we could find something on that baseline that would be indicative. But anyway.
Well, no, I think we will. Honestly, I mean, maybe I'm too bullish about this and too confident. I think it's a question of, how long it is, and then there's the whole kind of validation kind of piece to that as well, I suppose. But I think we will. I'm confident. Anyway, so should we talk about the other neoadjuvant study which Tara Mitchell presented? This is the UPenn one. I mean, maybe I can start off on the easy bit, and then I can just ask you the difficult questions, obviously, as usual. So I think at the top we kind of covered the study design. So then I guess maybe the question is, so if you escalate to adjuvant ipi-nivo in people who don't have a major pathological response, does it improve outcomes in comparison with carrying on with single agent anti-PD-1? And obviously there's a bit of a toxicity question in there as well. So I've just actually got the study design up on my laptop here on my left. So because I guess people will be less familiar with this than either S1801 or Nadina. So 70.
Sorry, but just to back it up, they just asked a really kind of cool and simple question. They focused on the path non-responders.
Yeah.
They said, look, it looks like if you have a great response according to the Nadina regimen, you are going to do good, notwithstanding a portion of them, maybe let's say 20% need something. But if you don't have a good pathological response, if you're a partial or a non-responder, did they look at the partial and non, or just the non-responders?
No major path response. I've just got the study schema up actually here. Yeah, let me just go through that. So 70 patients, clinical stage 3 melanoma, one dose of Nevo 480, and then going on to have surgery. So the major path response goes on to adjuvant Nevo, which is arm A, and then arms B and C are the ones who didn't have a major path response. And then there's a 1-to-2 randomization in that group between adjuvant Nevo, which is arm B, and then arm C is adjuvant Nevo 3 milligrams per kilogram and 1 milligram per kilogram of IPI. Primary endpoint RFS at 1 year. And then just a quick sort of footnote on stats, maybe, which they've said, this is reading from the slide, 30 subjects in arm C gave 83% power to detect an improvement in 1 year RFS. So, I mean, in some ways we could cut to the chase a little bit. I mean, maybe just to say something about toxicity. Of course, there was more toxicity in the ipi-nivo adjuvant than the neoadjuvant. We kind of know that already. And they also showed that major path response was prognostic of RFS, which we know already as well. But maybe for me, in many ways, the headline here was there was no difference in RFS or OS in those without MPR who are treated with either Nivo or ipi-nivo. And then again, from the slide, the median follow-up there was just over 2 years. So I think those were the kind of the headline clinical parts of that presentation. They then went on to some nice work actually about melanoma specific CD8 T cell monitoring, and they demonstrated the feasibility of that. So there are sort of 3-4 slides there, but maybe I'll pause so that you can say something. Or is there nothing to say?
There is something, and you just made me think of something with the Nadina presentation. So I think this is a really helpful exercise to say no real difference in escalating the regimen in the non-responders. And maybe this rewinds to something I said earlier, which is let's not just call it a failure of the regimen just because you didn't get a major pathological response. So that would be one way to look at this data. It's not that ipi-nivo is superior in somebody that fails to achieve a major pathological response. It's that nivo is not any worse. So sort of the idea that the regimen isn't necessarily a bad one because ipi-nivo is not coming in like a blockbuster. That might be one way to think about it. Obviously, with all the caveats of doublet immunotherapy in the adjuvant setting and all the problems we think about that. It made me think about Nadina. One of the things Minky pointed out is that in Nadina, for patients who did not achieve a major pathological response, they graphed, and maybe you have the slides there, they graphed RFS by patients who received adjuvant PD-1, i.e. BRAF wild type, and patients who received adjuvant BRAF-MEK, i.e. BRAF positive patients. And it didn't look like there was a significant difference there. And so I think her measured presentation of that was that right now, if you don't achieve a major pathological response, we're not certain if there's a quote unquote best adjuvant for PD-1 or BRAF-MEK. And then taking that with Thara's presentation, if you don't achieve a major pathological response, we don't think there's a clear winner, i.e. single agent anti-PD-1 or ipi-nivo in the adjuvant setting. So then I can ask you a controversial question. If you don't get a major pathological response, should you just stop anyway? Should everybody just stop at surgery? And then those that are cured with the neoadjuvant and weren't going to need anything, i.e. pathological complete responders, don't get anything more as they don't need anything, but you stop giving adjuvant because rather than let those patients have adjuvant that may or may not actually lead to durable benefit, let the ones that are going to recur, and then treat them metastatic with combination.
I don't think we really know the answer to that, do we? No. I mean...
Oh, no, we don't. I was asking you a controversial question.
Yeah.
What are you going to do in clinic when you give a neoadjuvant regimen and the path comes out with 60% viable tumor and you think, now I've got this patient who's been rendered surgically free of disease. I'm sitting in this adjuvant setting. What are you going to give them?
BRAF mutant or wild type, presumably.
Sure, let's start with wild type.
Yeah, well, I mean, that's the more difficult one. So the question is, do you sit tight or do you give more anti-PD-1? It's as simple as that. So then you've got the question of have they tolerated the treatment, which is me slightly avoiding the question, obviously, but in clinic, that's relevant. Do you know, and I'm going to dodge the question again, I think I'll talk to the patient actually about this. Am I really going to make a strong recommendation? I'm not sure I would, actually, which I think's fair. And then, you're smiling at me like I'm just dodging the question. But you could say, well, look, we can carry on. We can give you a load more treatment here with risk of side effects. I'm not really sure how much that's going to help at the moment. And I think different patients might react a little bit differently to that. Some will say, well, I'd like more of this treatment. Despite that, other people will say, no, let's just wait and see. But can I make a strong recommendation to do one thing or the other? I'm not really sure. Go on.
And by and large, let's say what we're talking about here. We're talking about really adjuvant PD-1 monotherapy. We're not really talking about the ability to use doublet in the adjuvant setting. And so
No.
if you're going to tell a patient, we didn't get the greatest response we wanted with your preoperative regimen, whether it was single agent or a combo, but now here's more of this single agent. That seems like you could understand how a patient might be like, what are we doing?
Mm.
And then when we say we just can't access combination for you now, but if we didn't get it all somehow, and your melanoma comes back, we've got combination. This is where, and I hope I'm going to say this very cautiously, as we see some longer follow-up from the adjuvant trials, and as they like to present us things like PFS1, but also PFS2, PFS, I would like to know what these adjuvant patients are getting at recurrence. And obviously, there's a couple of those flavors of recurrence. There's recurrence while receiving adjuvant therapy, and then what do you give them? Progression on active therapy versus recurrence after finishing your adjuvant year or stopping for toxicity, and there's some interval there. But I'm interested in what those regimens are, and then perhaps what that PFS2 looks like. I don't love PFS2, but there I can see why it would be a little bit helpful. It's always going to be messy in the adjuvant trial, but it's probably the only place to get this information.
Mm.
So for example, in a Pembro versus placebo trial, the group of patients who progress on Pembro, are they getting Ipi-Nivo? And are the group of patients who progress on placebo getting Ipi-Nivo? In which case it's a question of Ipi-Nivo as the quote unquote second therapy, though the first therapy was in the adjuvant setting, versus Ipi-Nivo just de novo as your first line therapy. To me, that's useful information. And so I hope as these adjuvant trials report out and we get longer follow-up, we see some of that. What did patients actually get? Build it into the database, capture what they get at progression, capture the next progression interval, because it speaks to if you've got neoadjuvant Ipi-Nivo at a flip dose and you stop, how effective is full dose Ipi-Nivo if and when you need it down the road? And that's a question we would like answered.
Yeah, all fair. But I'm also not a big fan of PFS2, as you know, and I think, yeah, it'd be great to see the data, but I think difficult to interpret, honestly. Lots of health warnings associated.
I mean, if you saw in Nadina for the patients who end up recurring, let's say at the 5-year mark, for the patients who recur, presumably you'd want to know the regimen they got at recurrence.
Yeah.
And then you'd want to know probably a PFS rather than an ORR at that point.
Yeah, I think so. Yeah. Sorry.
Sorry, London.
Traffic problems in Chelsea.
That's a massive cut there.
Ah.
Just cringe for the listener to hear that. Hopefully in post we can take that sound down. Anyway, but no, but I think then it's some comparison of the RFS they got from the first Nadina regimen to the PFS they're getting from the second, and whatever that disease-free interval is. There's some stacked bar graph I could almost visualize that would be useful for me. Did that go geeky for you, stacked bar graph?
Did that what?
Go a little geeky?
No, that's very exciting, actually. But, listen, that was great, and that was a really nice discussion overall, but we're already at 28 minutes and 30 seconds, so I think we might need to call this Best of ESMO 2025:1.
Let's just keep...
Really? Don't you think we should do another one and then do all the rest?
Have you watched any of our episodes lately? They're all banging on 40 minutes.
Yeah, but that's what I mean. So I think we've got enough in all the other ones to do, :2, like
Okay.
the best of the rest or something. Well, I'm not the boss. Yeah. Okay. So listen, let's stop there, and then we can do all the other stuff, including, and this is a teaser, isn't it, or an advert, or your presidential session in Best of ESMO :2. Yeah, come on, look excited. Okay, that's it. We've decided. No, I've decided. That's
Okay,
it.
good
All
job.
right.
All right,
Bye.
stay tuned.